Okay, good morning, everybody, and welcome to our webinar as part of our Women's Series in celebration of Women's Day and Women's Month. Sorry that we're running a bit late. We seem to have had some technicalities or technical difficulties of cameras of some of our speakers, but we're hoping to get that sorted out any minutes now. Thank you again. Thank you to all our speakers. Thank you for being here. Thank you for taking the time to be here with us and to share your knowledge and experience. Dr. Chanel Martinezson is going to be our host. I'm hoping that she'll be able to turn on her camera. Otherwise, we might just be able to hear her voice, and she's going to guide the discussion going forward. Before we start, I am just quickly going to play us a corporate video, just as an introduction from CTU, who is hosting this discussion, and from there on we will continue the conversation. Okay, thank you very much. I'm not sure if our other speakers are able to. Chanel, can you maybe hear us?
Hi, Johan, can you hear me?
Yes, I can hear you.
Okay, I can hear you guys, but I can't see you. Okay, and you can hear me, but you can't see me.
Okay, we're just going to have to carry on. I'm not sure what the problem or the challenges there is, but unfortunately, that's technology for you. Sometimes it works, sometimes it doesn't.
Yes.
And for some reason, it seemed to be not working for us at this moment. But if you're able to carry on that way, Chanel, thank you very much.
Yes, I'm able to. So I'll welcome everybody and kickstart. Is that okay?
Yes, yes, please.
Okay. So good afternoon, everybody. Welcome to the webinar. I apologize that you can't see my face right now and that I can't see your faces right now. But I am Dr. Chanel and I am your host. It's a little bit embarrassing that you can't see me even though because I'm the head of virtual care in my company. So this is a bit of a problem, but this is like Johan said, this is technology. It works sometimes and it doesn't. So just to introduce ourselves and what we're doing here today, and then the panelists will introduce themselves. So in a world where women's health and wellness are crucial components of societal progress, our panel of experts gathers to discuss the challenges and opportunities in achieving comprehensive well-being for women, from battling cancers to addressing gender-based violence, promoting sexual and reproductive health, and nurturing mental well-being. This dialogue aims to shed light on interconnected issues that shape the lives of women globally. So I am Dr. Chanel, as I've mentioned. I am a general practitioner and I currently work with Inner Health Technologies. It is a company, it is a health tech company, and I am the head of virtual care. I'm also the founder of a women's wellness platform called The F Word. So that's a little bit about me, and both of these topics, the virtual care and the women's wellness, it's dear to me and I'm very passionate about it. So I'm excited and I'm honored to be on this platform with you all today. I'm now just going to ask all of the panelists to introduce themselves. So because I can't see who is here, I'm just going to start is Dr. Stavros Nicolaou here?
He is here, but we can't hear you, Stavros. We can see you. There we go.
Am I audible?
Yes.
You are audible. We can hear
Wonderful.
you.
Right. Thanks.
I'm so glad that you're me on this conversation as well. So you can go ahead, Dr. Stavros Nicolaou, to introduce yourself.
Thanks very much, and good afternoon to all my fellow panelists, and of course to all the wonderful people that have dialed in to listen into this webinar. It's a webinar that is both timely and important. My name is Stavros Nicolaou, and I wear a number of hats for purposes of this conversation. However, I'm going to confine it to two. My first capacity here is that of a group senior executive at Aspen Pharmacare. Aspen is Africa's largest pharmaceutical manufacturer and also an organization that has been highly in tune with and responsive to various pandemics, whether it's been HIV, multi-drug resistant TB, and more recently, of course, the COVID-19 pandemic. And then the second hat that I wear today is that of a business unity South Africa, which is the apex business organization of our country. I'm a board member, but importantly, I chair the health policy committee of BUSA. It's a great pleasure to be here and look forward to the participation.
Sorry, can you hear me?
We can now, yes. We can now.
Thank you so much, Dr. Stavros Nicolaou. Our next speaker who can introduce themselves is Dr. Richard Botha.
Yes, Chanel, thank you very much. Thank you for inviting me to speak on this. I think it's a very important topic. Like Stavros said, I'm on the other side of the spectrum. We do health risk assessments across the country. We've got a huge nursing fleet out there that see people every day. And then following on to that, we do health coaching. We've got online platforms where we coach people of all spectrums of society on how to look after their health better and how to get better life and health outcomes.
Thank you so much, Dr. Richard Botha. I'm so glad that we've got men on the panel today talking about women's wellness. That's very exciting. It means we're moving in the right direction. The next speaker who can introduce themselves is my dear friend, Sasha Laurel. Sasha Lee, are you here?
Thank you so much, Dr. Martinez. Pleasure to be here. I think the reason why I'm here is I often believe that we deal with issues around education in silos. So we only deal with the issue of education. We don't often involve healthcare. So I think I'm just here as someone who is in education advocacy, as a software engineer, as someone who has a passion for education and wellness of society in general. Being a former Miss South Africa, I think, you know, the importance of service is at the heart of everything I do. And I'm just so happy to be here and share and be on this panel with such incredible people. Thank you.
Thank you, Sasha. Is Shivani Govender here? Can you introduce yourself, please?
Hi, Chanel. Hi, everyone.
Hi.
My name is Shivani, and I serve the Legal Expenses Insurance Group of companies in the capacity of executive responsible for people and culture. And I also support a few organizations with regards to their executive and performance coaching needs, mainly focusing on personal mastery and leadership development. It's a real pleasure to be with all of you this afternoon. Thank you.
Thank you so much for being here. Is our second last speaker, Busisiwe Mzandolo. She here?
Yes, yeah. Hi, everyone. As we've mentioned, my name is I am a private therapist, so I own a company called Health Culture Consulting.
We struggle to hear you a little bit.
You break, you go coming in and going out.
Hope it's not the network. Can you hear me now?
Yes, much better.
Can you hear me now?
Yes, just try and speak and then we'll
Is it clear now?
Yes.
Okay, so I own a company called Health Culture Consulting, and we do counseling for individuals, families, kids, anybody that would need therapy, whether it be mental health, whether it be psychological help. That is what I do. And I also own a company or an NGO called Aguamanda. That is where we now support the women, where we empower women, where we do events for women so that we can be able to empower them in the community.
Busisiwe, I think it might be if you're moving while you're speaking, it comes in and out of the speaker.
Okay. Can you hear me now?
Yeah, I think maybe if you are you using headphones or your phone? Because it comes and goes. But I think we heard most of it. You said you own an NGO called Akuwe Amandla, where you empower women. That's the last we heard.
Yes. Yeah.
Okay. Thank you so much. And then our last but not least, can you introduce yourself, Anele Ndlovu? Are you here?
Yes, I am here. Can everybody hear me?
Yes.
I'm finally on screen. I also was having it.
I'm so glad you got onto screen. I wish I was on screen.
Yes.
You can introduce yourself, Anele.
I'm very happy to be here. I am the founder of the Tea with Anele Ndlovu, which is a women empowerment and women leadership activist group. But it has a very big focus on mental health advocacy. And I've had the great pleasure of working with Ubusi as a therapist on events and projects and workshops that we do around mental health advocacy, specifically for women, but we also work with men and we also work with young people. And today, you know, we're just here to talk about your mental health and your mental well-being.
Thank you so much, Anele. We are happy to have you, and we are happy to have all the speakers here. So I gave a little bit of an introduction to myself. I think we have a bit of a similar interest with Anele with the empowerment, especially with your tea with Anele, because my platform is called the F word, which stands for freedom, and it stands for female, and it stands for flow. And that is really what we would like women to feel, free to just be themselves and to speak about the things that are actually bothering them and not to live in silence. Let's kick off the discussion. We've got a few topics to get through and a few speakers. So I'm just gonna kick off, and I'm so happy that we do have men on the panel speaking about women's health and wellness. It really is such an honor to have you guys here. So Dr. Stavros Nikolaou, we'll start with you. So opening the discussion, we recognize the alarming statistics surrounding breast and cervical cancers. 500,000 women succumb to each of these cancers annually. The significance of comprehending women's epidemiology, particularly non-communicable diseases, sets the stage for a holistic approach to women's well-being. I would like to ask you, Dr. Stavros Nikolaou, how does understanding the epidemiology of diseases like breast and cervical cancers, which are leading causes of death in females, contribute to improving women's health globally?
Right, thanks very much for that excellent question. Can I preface my response by firstly making some observations? The first is that, sorry, I hope I'm audible, right? You can hear me, right?
We can hear you. Yeah, the first is?
Okay, so the first observation is that we've learned many things from COVID, but one of the single biggest lessons is the extent of the impact of health inequality. And this was particularly manifest on the African continent. And although there is vast swathes of inequality, it seems to be more skewed towards women, firstly. The second thing is that we have also realized now, as a learning from COVID, the impact that pandemics, epidemics, whether they're regional, continental, global, the impact that they have on lives and livelihoods. So that segues me into the response to your question. And of course, we should recognize that the three most prevalent cancers that affect women in our country are number one, breast, number two, cervical, and number three, colorectal cancer. Those are the three. But the first two are highly predominant and also highly avoidable. So what I do want to leave by way of a message before I discuss some of the epidemiology around this is that early detection and early screening lends itself to very good outcomes for both breast and cervical cancer. So by way of example, in cervical cancer, there is an HPV vaccine, human papillomavirus vaccine, and if taken timeously, this is in your early teenage years, the prognosis for significant reduction in cervical cancer is a highly favorable one. Similarly with breast cancer, if you do basic screening, like feeling your breasts, looking out for certain symptoms, signs and symptoms such as an irregular discharge, swelling in the breasts, nodules under the armpits. There are a whole host I could go through. We don't have the time to do that, but suffice to say that if there is proper screening, then the outcomes can actually be very good, because I know a lot of women have this great angst and say, well, my mom had cancer of the breast, am I going to get it, etc. I think the best preventative measure here is early detection, and early detection leads to very good and successful cure rate. Now, in terms of packing your question a little more and understanding the epidemiologies, right, I think that what is obvious here is that if you don't understand these trends and you don't understand where and how people are being affected, then your response is not going to be a particularly good one. And we do have, both for cervical and breast cancer, both have been declared as national health priorities by our government. And there is a protocol that gets followed, but the protocol can only be followed, and we can only better understand these conditions and better manage and handle them if patients report early and if patients are doing the necessary screening. So from that, we do get epidemiological data. For those of you who don't understand the term epidemiology, it really refers to working out disease patterns. What are the patterns? And through those patterns, you can more effectively deal with these conditions. And the same applies to both breast and cervical cancer. So this lends itself to a more targeted approach. We know that our country grapples day in and day out with healthcare challenges, and particularly resources, especially in the public sector, but not only in the public sector. And a part of understanding these epidemiologies or these disease patterns is that as we speak here right now, there are still significant access challenges. So many women cannot access appropriate, suitable, and equitable intervention at the right time. Now, what do I mean by this? And I'm going back to your question around the value of understanding these disease patterns. The value of educating women, the Enlightenment, prevention is the best cure to anything, as you know, and the better equipped, educated, and informed you are, the more likely you are to get early detection and therefore successful cure rates. So one of the things that is highly challenging from an access perspective is that if I just take breast cancer, for example, and these cancers these days are very much diagnosed through biomarkers. These are markers that help us understand the gene mutation and to provide effective therapy, and some people call it a targeted immunotherapy. So these immunotherapy drugs, which are fairly new, many of them are called MABs, which stands for monoclonal antibodies. So you've got MABs, NIBs, and CAR-Ts. Don't worry about all of that. Just understand that we can target these cancers these days, but the patients have to have access to diagnosis, which is very often not the case, and they've got to be able to access these drugs, which are very often costly. And therein lies the most immediate challenge and the next frontier of challenge in our country. We've spoken a lot about HIV, TB, malaria, but the next frontier that we need to confront is non-communicable diseases, and cancers, particularly female cancers, are near the top of that list. So the last message I want to leave you with in response to a question is that the inequity and inequality gap still persists, and this lends itself to less accessible treatment. So for 20% of breast cancers which are responsive to something called an HER2 intervention or HER2 receptor intervention, the cure rate is around 94%, the efficacy rate. So you could see 20% of breast cancers are curable if patients can get access to these HER2 responsive immunotherapies. So I'll leave it at that, because we'll unpack that no doubt a little later. But sort of a final concluding message on my side is, ladies, please go out there, screen, detect early on. If you do so, then the cancer becomes extremely manageable and curable. And let's also use today's webinar and Women's Month in general to agitate for more accessibility to both diagnostics, medical devices, and history. Thanks very much.
Thank you so much, Stavros. That was very informative. I'm so glad that you have touched on what epidemiology means, just in case somebody didn't understand it. So it means disease patterns. And I'm so glad that you touched on the screening and how important that is. I would just like to add that pap smears Females, you can get your pap smears done at your GP and a gynecologist. You do not have to wait for that to be done. A GP is eligible to do it. And also getting it done as soon as possible. At least if you leave this webinar today and you've never had a pap smear before, please make an appointment to have a pap smear and or a breast exam. As Stavros said, it is two of the leading causes of deaths, cancers. So thank you so much, Stavros. Transitioning to maternal health, the focus shifts to sub-Saharan Africa, where childbirth-related deaths remain concerning. The panel delves into why maternal deaths persist despite the potential for prevention through access to family planning and basic services. Dr. Richard Botha, could I ask you, what are the key factors that contribute to the high maternal mortality rates in sub-Saharan Africa, and how can these challenges be addressed?
Thank you, Chanel. I think this is a lot more basic than the subject that Stavros touched on. And lots of it we have to recognize is cultural. It's driven by that. And then education is probably the second part that drives quite a bit of that. So let's just concentrate on South Africa at the moment. And we can then easily, when we look at the statistics that we get, there are three parts to that. The one is missed opportunities, and that goes back to the patient or to the mother or the mother to be. The second of that is access to care, and then the third one is then substandard care, which is a reality. We can paint that all we want to, but that is the reality that we look at. So if we look at the patient themselves, the mother, the highest percentage of issues that lead to death is uncontrolled bleeding. Now, if we just take a wider look, then we see that by 2025, 85% of South African population will be urbanized, which probably indicates that access to care should be easier. And yes, as Stavros referred to, there's still a huge disparity in access to care across population groups and income groups in the country. And that's not something that we're going to solve overnight. But the access to care does play a role, but the patient must first seek access to care before care can actually be given. So because of a trend that we see that lots of mothers are very young and probably don't always understand what is happening, and that is where the complications come in. So they are not always very attentive on looking after themselves. They do not go for antenatal classes and care, which is in general offered at clinics and hospitals. And then they're not very good at recognizing important warning symptoms and signs, not obviously like severe headaches, vaginal bleeding, those kind of things, which is always indicators that there's something wrong. And often help is sought too late because the symptoms was not reported early enough. So that is, and that constitutes very close to 60% of the reasons why we see such a high maternal death rate in the country. And you can probably extrapolate that to Africa, but then we cannot forget about underlying undiagnosed chronic conditions and infectious diseases that play a massive role. And it goes back to also understanding what you should be looking at and what you should report to a healthcare worker. And that is why education is so important. And we forget often to, or we think that education must come in the formal setting like we all used to that. But one of the biggest money spinners on the continent is data, which indicates that the vast majority of the population on the continent hasn't got access to mobile phones, and that should be the focus on education. Even if the populations that we're talking about don't always have access to high-end care, to antenatal classes, to ICUs and those kind of things, that they are educated to understand the situation around them, when they should seek help, and when, if possible, travel to a better institution that will help them, where there is the competent staff that they're looking for, that's got the adequate training, and that they can be under the care of a highly trained nurse or doctor, so that all the risk factors can be addressed. So those are the driving factors. And if you speak to gynecologists in private and in state hospitals, that's what they find most. And often when they find the patient, or the patient finally find their way to them, it's often too late to do anything about it. Resources is always going to be an issue until that can be fixed, and the population growth is probably outstripping the ability of the government to supply enough of those resources. So it's something that we have to work around, and therefore your very young mothers must always be educated, cared for, and made sure that they get to the right facilities and they get the right information before having the baby, and even after, to make sure that both mother and child survive, and the child can grow to adulthood. So those are the touch points that we can discuss, but I think that is one of the driving factors that is causing such a high mother mortality rate in sub-Saharan Africa, and specifically in South Africa. So let's leave it there for now, and it's a massive problem. It's a problem that we need to address. Our friend in the States, Elon Musk, keeps on going about a repopulation problem that we've got, and if we really analyze the economic factors and how our aging population is looking like, he's probably right. But it's traumatic for communities and families when mothers pass away in childbirth or before childbirth, and I think we lose fantastic resources for the future generations when we lose mothers, and that is something that really must be looked at, and that we can address that, empower women, that they can understand what is happening to them, even if they're very young, and make sure that there's positive outcomes in the whole process for everybody.
Thank you so much, Dr. Richard. That was very insightful. I think the common thread so far is accessibility and education. And I think that education should, like you said, start from a young age. Young girls and young boys should know what types of things to look out for, what the danger signs are. And it's the health, even before they become mothers, that causes the high maternal mortality rates. So now, a crucial aspect of women's well-being is their sexual and reproductive health, as you said. The dialogue, now we'll delve into the challenges posed. Sorry, somebody's mic is on. It's just causing some interference. Can we just check that our mics are not on? We'll now delve into the challenges posed by the lack of education and services, as previously mentioned, especially affecting women from disadvantaged backgrounds. Ms. Sasha Lee Laurel, what are some of the barriers that hinder women, particularly from marginalized backgrounds, from accessing proper sexual and reproductive health services?
So thank you, Chanel. I think there's definitely a great deal of intersectionality with respects to the barriers women face in reproductive health. Now, although, as we've mentioned earlier, education seems to always be the baseline, what's often neglected, and I think Dr. Richards touched on it earlier, is the fact that we need to understand that this transcends traditional forms of education. It transcends the classroom. It's the socialization process. It's the existence of theocracy, societal roles, that shape and basically just govern how we approach education and create the syllabus necessary. So I think the focus, and definitely a barrier for us, should be ensuring that education around consent, family planning, needs to be effectively brought into schooling systems. The importance of agency for both boys and girls should be highlighted in this respect. I think we can't solely rely on the fact that children would be children, especially when statistics don't indicate that at all. I think that brings me to the second point, and it's language. Language that's used in the media, language that often perpetuates violence against women, high rates of gender-based violence in our country. And I think it's very important for us to properly define things and ensure that it's in line with the laws of our country, because I definitely believe that there's a certain level of disconnect between what's implemented at the level of the executive and what's experienced on the ground. And unpacking the words like teenage pregnancy and what it is exactly, because our inability to correctly define this thing, which is in actual fact rape, because there is no consent, I don't see how we would be able to solve this, because a big form for me of reproductive health for women is the issue of unplanned pregnancies. And I think, you know, as older people, we can often soldier, you know, stand together in solitude and take on things, but kids need superheroes, kids need people to look up to, kids need protection. And I think more so within the law itself, and it's important for us to define these things and say what they actually are, because there was a study in, I think it was in Barron and others, in a South African medical journal. It said that in 2017 to 2020, the kid or little girls aged between 10 and 14, pregnancy had risen by 49%. And this was between 2017 to 2022. Very scary numbers. And we saw that in COVID, it had increased by 60%. So it's very important for us to call things what they are. I think if there's a baseline and it's education, it's important for us to label these things correctly so we can accurately find these solutions that we're looking for.
Thank you so much, Sasha. I'm so glad that you also mentioned that the education transcends the classroom. There's a saying that goes, 8 is too late. So moms and dads, if you have daughters and sons, you should be talking to them about these topics from before the age of 8, from before they start to menstruate or go through the different pubertal changes that they're experiencing. You should take the shame out of those conversations. And that would start to make these conversations more normal. So yeah, societal norms, stigma, misconceptions, and taboo continue to perpetuate exclusion and discrimination against women and girls. Now we'd like to explore the impact of these factors on menstruation, reproductive and sexual health. So my biggest passion is talking about menstruation and reproductive health. Ms. Shivani Govender, could I ask you, hi, how do deeply ingrained societal norms contribute to the perpetuation of taboos surrounding women's reproductive health, and what steps can be taken to challenge these norms?
Yeah, you know, I think you touched on so many important aspects around it, including the dialogue and the conversation that needs to happen, not just with girls, but, you know, with boys. And I'm a mother to a 9-year-old son who's already asked me questions about these things. And I think it is about normalizing it in such a way that it doesn't feel like it is something strange or bad, or that you're doing something wrong. And I think that's what leads me to the first part of this, which is, where do these like norms, you know, come from, and where are the taboos sitting? And I think if we examine it closely, it pretty much stems from historical beliefs, cultural traditions. I would even go so far as to say economic interests. that have definitely shaped our views on both how we see women, how women see themselves and their bodies and their roles, and how society views women over the last couple of decades. And I think these taboos have incredibly far-reaching consequences, which we are already seeing just on some of the stats that have been shared with us, that it's actually not getting better, it's getting worse. And I think for me, that's always the question is why? With so much of access, right, to the internet, with so much of access to help services, far more than if we look at, you know, a good couple of 100 years ago, why does it feel almost as if it is getting worse? And I think a big part of it is because of where the responsibility is viewed in addressing the taboos and the societal norms. You know, so I want to share a quick story with you that I recall when I read, you know, what our webinar would be about today. I recalled for me the first time that I was spoken to about menstruation. And I think I was one of the lucky ones in that both my parents, my mom and my dad, sat me down and spoke to me about what menstruation is, and that it is not viewed as something that is dirty or bad or whatever may have been things that are shared, you know, in your circle of friends, that it came from a reliable source and from people who I trusted, which as a young child, that starts with the people you live with. It starts with the parents, it starts with who the caregivers are. And I think that already set me up for success in understanding that it's something I should be talking about. It should be part of our dialogue. It should be part of how I grow up. It should not be something that I have to ask a friend about who may mislead me. And I think that's a big part of dispelling these societal norms that exist at present, because it starts at home, right? It starts with boys and girls. It's inclusive. And if we expand that a bit further around, you know, where is this taking us to from a corporate perspective and from a public sector, I think it is a collaborative effort that requires everyone to start having those kind of conversations. You know, I think back to women in leadership roles that I've spoken to about their challenges around their reproductive health and how for some of them it still feels, given that they occupy a minority space in the boardroom, something that they can't really speak about because it may be viewed as them being weaker or now needing time off or a stressful situation. And I think it still is pervasive in the corporate culture that it's not spoken about as openly as it should be. It's not something that is encouraged, and policies in particular in South Africa have not yet evolved or progressed to a space where it is far more flexible and inclusive of things like this time of the month that happens, the fertility issues that so many women are experiencing, the whole concept of family planning, and the time off that it would require for a woman to be a mom, and particularly how that potentially still today has a detrimental effect on career progression. You know, so many women that I speak to still talk about how it's a weighing up. It's no longer an and, it's an or. You're either career focused, and that's what you're going to do, or you're going to make lots of money and hire yourself in a place so that you can actually do what you need to do in the world of work. And I think it has not, certainly in South Africa yet, gotten to a place where this is what we're talking about, more so in the environments and the spaces where we can actually air views and be more inclusive about it. And I think COVID really brought that to the surface, you know, with remote working and with all that happened at that point. And then you saw suddenly organizations getting everyone back into the work world and the kind of pressure that's put on women in particular, who tend to be the main caregivers. So I do think it is a all-encompassing and very much one of those challenges that requires a couple of prongs to address. But as we've seen in the conversation so far, probably starts with education and awareness. My personal view, it starts at home first, in that safe space that is meant to be there for women and boys, for young girls and young boys to talk about, and then to be expanded into educational systems, and then of course into the world of work, which I think still has a long road to walk with regards to dealing with the societal norms and the taboos that plague our beautiful country. Thank you.
Thank you so much, Shivani. That was speaking to everything that I stand for as a woman as well. And I actually also thought back to the time when my mom spoke to me about menstruation, and the platform, the F word, is also, I called it the F word because it relates to a euphemism where people, they don't say things for what they are, and they speak, in like the birds and the bees and this and that and this time of the month. We should start to call it what it is. We should start to take the shame also out of those words, like bleeding and contraceptives and sexual health. And, like we should start to speak about it, like you said, as if it's a normal topic. It should be spoken about around the dinner table, and it should just be a normal topic of discussion. So thank you very much for touching on that. Now, Busisiwe, we'd like to confront South Africa's distressing rates of gender-based violence, which impact women's mental, physical, and reproductive health. Societal and cultural norms' role in perpetuating violence is examined. How do societal and cultural norms contribute to the prevalence of gender-based violence, and what can be done to change these harmful perspectives? Busisiwe Mzandolo.
Hi, I hope everyone can hear me. I had to switch off my camera. It keeps on making me too black. Am I clear enough this time around?
We can hear you clearly. I can hear you.
Okay, that's perfect. So we're touching a very sensitive topic when it comes to GBV, because we cannot take it to the tip of an iceberg to just say it's just gender-based violence. But it's got a lot of elements within it. It's got a lot of cultural norms within it. Most of us have grown in families where GBV is a normal thing. If you're disobedient, you need to be beaten. We come from schools where if you say something to a boy, he can hit you on the face, and that's okay. We come from families where if your brother went to the mountain, if you guys are familiar with that, when he comes back, we need to give them that respect of ubuti. And the minute we say something that is not respectful according to him being ubuti, he has to hit us. And my mom will be like, no, it's okay. You have to be beaten because you disrespected him. So now take that as a society growing up in a space of it is a norm to hit somebody. It is a norm to fix somebody by hitting them. Now, when it comes to gender-based violence, we're looking at it on the female side of things, because now we are empowering women. Now we're empowering all the females that we are talking to right now. And we're looking at it, how did it start? From where did this narrative come from? Did it come from the fact that one was sort of educated to understand and accept that as a woman, when I am wrong, somebody needs to hit me? I hosted an event yesterday, and there was a Zulu guy in the event. He said, I would tell my woman back in the days, you do this wrong, 1. You do this wrong, 2. You do this wrong 3 times. The 3rd time that you do it again on the 4th time, that's the end of you, meaning you are already expecting to be violated, whether be violated physically, whether be violated emotionally, whether be violated psychologically. Now, you're asking, how can this whole narrative change or be changed? I think we focus more on the impact as a country or as a society, or as even if you go to court, we only focus on the fact that you were beaten, you've got a face that has been turned around by this person. We are only focusing on the impact. But do we all focus on where it started? Do we focus on educating the change of how GBV started? Do we focus on making the little girls to understand that it is not okay for anybody to do any physical, social, psychological talks that will make you feel less of yourself, that will make you feel like it is okay for a guy to tell me that my bums are big? And because that's also part of starting with a GBV. Whenever somebody gives you something, or whenever somebody speaks about your body and you accept it, that's the start of accepting the whole gender-based violence happening into your life. because the physical is the one that now is evident. Emotional, because gender-based violence starts with emotions. It starts with internal. It starts how we perceive ourselves. It starts how we see ourselves because of how we've been educated. So I think we've been talking more and more on this platform about education. And I think it's most important to say anything that needs to be changed, we need to make it a topic. I always say I go around as Busi the therapist. Why? Because I want people to understand that therapy is not a taboo. I want people to understand that going to therapy, whether be it for emotions, whether be for psychological, whether be for family, it is not a taboo. It is a cool thing. It is a norm. It's something that everybody should go. Now it goes back to educating the rights and wrongs of GBV in our society, in our families, in our churches, because sometimes your husband will beat you at church and the pastor will sit you down to say, no, it's okay, respect the man, he was doing his duty. So we need to educate about it so that this narrative can be changed, not only by us as therapists when we're into the therapy space. Somebody must come into my room with the knowledge of, I know what was done to me was not okay. I know what I have done that caused the other person to do this to me was not okay, which means I acknowledge myself first, and I acknowledge the role I played, and then I acknowledge how this person turned out to be because I was also in that space. I think I'm more or less answering or covering, because gender-based violence is very broad. So I'm sort of covering, putting it in a narrative of understanding how can we change that, and how can we improve that, and how can we make sure that our woman goes out there and start dating people knowing and understanding that what it is, how it started, how do I change it, how do I remove the family education, how do I remove the society that they've told me that this is right and this is wrong. I'm not sure if I'm answering exactly how you would have wanted it, but I can elaborate more if you can probe. But I think more now, my aim was to show that GBV is quite big. But when we're putting it into a narrative, it comes from our cultural backgrounds, it comes from our families, it comes from our society. So with education and this word being a normal word, not a secretive thing, we need to talk it as if we're saying, I'm in love. If you can say to the world, hi, I just met somebody, I'm in love. You must be able to just say, I just met somebody who just kicked me and that was not okay. And we don't feel like, oh, why are you talking about this? That's the level I would love it to go into.
Thank you so much, Busi. You're making me think of the song, My Body's Nobody's Body But Mine. I don't know if you know that song, but
Yes.
that was all that we were taught at school. And it just reminds me, yes, at school we were taught that our bodies, it's nobody else's, and we have the right only over ourselves. So thank you so much. I know it's a big topic. It probably can't only be in this 90 minutes conversation. But yes, thank you very much for touching on the societal contributions. And I'm glad you also touched on therapy and that it is a normal thing. I think that women and men have a lot of things that could, that they could speak about. And a lot of those things, if they had just gone to therapy for it, that might not have even ended up in GBV, So I'm so glad that you touched on therapy and how important it is for us to speak about things that bother us instead of taking it out in other ways. So
can I just add one thing?
Yes.
Yeah, just a little bit. Yesterday, on Saturday, there was a lady who was sharing that she's getting married, but she has seen the signs of the husband beating, cheating, doing all these things, dreamt about it, also seen it as well. And my advice as a woman in the space was, okay, come, let's talk. Let's understand you first, self-love and everything. And then a man came to the platform and he goes, culturally, you need to go back to your gods and your ancestors and ask them, is this the right way of doing things? Instead of saying he is wrong as the husband who's doing all these things, he kept on putting into the cultural side of things to say, culturally, it's okay. Just go consult with your gods. Now you are taking a woman who's vulnerable and you are giving them back to the same man that's going to destroy their character to say, what about your culture?
Yeah.
What about your gods?
And that's how this.
It is.
Exactly. And that's how the cycle just continues and continues, and it's just a cycle. Thank you very much, Lucy, the therapist. So, yeah, moving along, we are nearing the end, so I hope that you guys are still with us and that you're enjoying it, and it's been some tough topics that we've touched on, and there will be a few questions in the end, so just bear with us a few more minutes. Now, women juggle numerous roles in their lives, leading to challenges that affect their mental health. We'd like to now delve into the societal pressures, career aspirations, and maternal responsibilities that often impact women's well-being. I know that this has been touched on before, but Anele Ndlovu, how can women recognize when their mental health is declining, and what resources are available to support them in maintaining their mental well-being?
Hi again. Thank you for that question. And thank you to the previous speakers for their contributions. It's been very interesting to listen to them and to learn from them. So with regards to mental health, I think I share similar sentiments to Busi in terms of, you know, society and culture and how those things play into people, and then women specifically in getting help and actually recognizing when they are not okay. You know, only now are we starting to talk about anxiety, stress, depression, other mental conditions more openly, and people are only now starting to give therapy from the likes of Busi the therapist and other people. But previously, there is still a stigma around mental health, and that's why a lot of people don't get the required help that they need to get, you know. And so because of the stigma, the taboo around mental health, there's a lack of education around it, and there's a lack of awareness around it. And so someone may be going through something, maybe similar to like a GBV case, like what Busi was mentioning, which is impacting on their mental health. But because of the lack of information and the lack of education, they're not going to know exactly what is happening to them, and then they're not going to know how to get the assistance for that. But for me, when I'm thinking about this question, it came to how can a woman know that her mental health is declining? For me, it's on self-awareness, you know. And I will take myself in as example, and I'll use myself as an example that 3 years ago when I was retrenched, at that moment in June, I got the news, and when I got the call, I was shocked, I was angry, I was confused, I wanted to cry. You know, the meeting was on a similar platform like this, where my boss is giving me the news, I'm acting strong, but all I wanted to do was for the call to end so I can just let the tears come down. But it was only at that moment where I allowed myself to feel something. After that, I phoned a friend of mine, I told her what had happened, and I just said to her, I don't want to be alone tonight. And she said I must come to her place. We chilled. But after that, I wore a mask for months. You know, I mastered as I'm okay. I've got a great CV. I've got great connections that I've made. I'm sure I'll find another job. And I never really gave myself that time to really feel, what does it mean that I don't have this job, that I don't have this role, that I don't have this company, all these things that I was about, you know, my identity, my reputation, they were all around my career. And now that just is no longer there. But it took a breakdown, it took a blackout, it took a really, I don't even know, like an almost devastating situation for me to be honest about what it is that I was really going through. It took 7 months from that time when I received the retrenchment news for me to say, I actually am not okay. But if I can be honest with you now, I knew back then that I wasn't okay because I know myself, and that's where the self-awareness part comes in. And that's what I would like people our guests, our speakers, anybody who's going to watch this, just to remember this. And this is what Busi, the therapist, you know yourself, you know the things that you like doing. When you start not doing those things, you should check in with yourself. What is it that I may be going through that is making me not do the things that I like doing? So I like walking, I read the Bible, I read books, I journal, I like to go out with friends and meet up with people. But I remember back then that I actually stopped doing a lot of these things. I wanted to be alone, and I usually like being around people. You know, I wanted to be alone. I didn't exercise anymore. I wasn't reading, I wasn't journaling. And it took me such a long time to actually be honest with myself that something is wrong. And by that time, it was so late because then I was diagnosed with depression and I had to be on medication. I had to see a psychiatrist, a psychologist, and it ended up in a suicide attempt and admission at a psychiatric center. But I always encourage people that the minute you feel off balance, the minute if you are a person who likes gym or you're a person who likes reading, and maybe a couple of days go by and you're not doing these things, just check in with yourself. You know, what is it that you are going through? Are you stressed at work? Is there pressure coming from work? Is there pressure coming from relationships? Is there pressure coming from any, I don't know, maybe social aspects or things like that, that you can just say, I need to take a time out. I need to just come within myself, see what is wrong. How is it that I can maybe alleviate the stress or the pressure that I'm under, so that you can pick yourself up and get to doing the things that you like doing. And you can do those check-ins, but like Busi has said, let's make therapy part of our lives. So if you are feeling that you are stressed, you're anxious about something, or you're depressed about something, reach out to a professional. And you can just, even if you're not sure what it is that you're going through, but you know yourself that I'm not feeling like myself, those are resources that you can go to get help and just to talk to someone, especially someone who doesn't really know you, because they can be objective in how they listen to the things that you are saying, and they can provide the help that you need. And some people may also then need medication. So going to, you may not be sleeping, you may not be eating properly, there may be something wrong physically with you. It's to then tell your doctor that I'm just not feeling like myself. I'm not sleeping, or I'm oversleeping, I'm overeating, or I'm undereating. I'm not sure what's wrong, and they can run some tests for you. But I think the biggest thing is the self-awareness, but being okay to say that I will go through times when I'm not 100% myself. I will go through times when I am stressed and when I am anxious, and making that okay. Because I know from experience that wanting to be strong all the time and wanting to be perfect all the time is what then delays our recovery and healing process. Because by the time you then admit and accept that things are not okay with you, there's so much more work that you need to do in your recovery and in your healing. But if earlier on, when you start feeling that imbalance and that instability, it's just to say, let me get help immediately, you know, or even make it, you know, I work with Busi quite a bit, so that's why I keep referring to her a lot. She always says that maybe at times we shouldn't wait until something is wrong for us to see a therapist. You don't have to see a therapist maybe every month, but once in a while, check in, you know, check in with even a coach, you know, how are you feeling? Are you on track with any goals and things that you've set out to do? What could be holding you back from them? Because a lot of the times is we have all these plans that we want to do, and maybe we feel we're not getting to them and we feel stuck, and that adds a lot of anxiety and stress to ourselves. But actually speaking to someone who is skilled and who's knowledgeable in either career or relationship or sports or anything that may be stressing you out, if you just speak to them, they may be able to help you get unstuck and know what it is that you can do to move on from the position that you are currently feeling. Thank you.
Thank you so much, Anele. Thank you for speaking so openly about what you've been going through. And I hope that you've encouraged other people to actually be bold enough and be brave enough to actually speak about things that they're going through. Because I think in the society we live in, social media makes everything look so perfect. But we actually should be sharing those imperfect things as well, because nobody's perfect. So everybody's most people are going through the same thing actually. And I like that you touched on the self-awareness and actually just checking in and saying, how empty is your tank actually? Like, how much can you actually give of yourself today? And what other things should just wait for today? So thank you very much. As a doctor, I would also just like to add that mental health is a real illness. Just because we can't test for it, there's no mental health thermometer test where we can do, because you can't see it. But it is a real illness, and it has a place. There could be medication that could help, and there is sometimes we just have to have the therapy and speak about things. But it is a real illness. So I would just like to leave that and add that to what you were saying. So thank you very much. We are nearing the end. Thank you to all of our expert panelists. We will now have an opening for questions. If anybody has a question for any of the panelists. Johanna, I can't see if anybody is asking anything. So maybe you can just assist with facilitating that. But if there are any questions, you are welcome to ask them now. Okay, nobody? I think that all of the topics just, I think, made everybody just, open their minds to think about all of these things. I think that it touched on a lot of emotional and deep things that women and men deal with. Is there a question?
So I actually wanted to ask a question from me to Busi. I just wanted to find out from you if there was any way our justice system, because I feel there's a lot of secondary victimization from the justice system, because I guess I guess the perpetrator's innocence until proven guilty, and then the survivor is, she's lying until proven otherwise, or he. How would you suggest maybe the justice system creates maybe policy or any type of mechanism that could actually make this work out a lot better, where there was a certain level of facilitation that allowed people who have survived gender-based violence to actually feel comfort in speaking up?
So I once worked at is it Cambridge? What court in Katlehong? There's a court in Katlehong I once worked in, and I would get a lot of these GBV cases. And on those case management, we would sit with the magistrates, the prosecutors, and all of that. Part of my suggestion was, when people report GBV cases, it's important to include not just a social worker, but a therapist as part of the law. Because I think with social workers, what they do, because there's so many cases, they record and leave and pack, and it's stats. And because of that, they tend to neglect a lot of these really serious cases, because they're pushing work, they're pushing admin, they're pushing case closure, even at court, they're pushing the stats, how many people, how many cases were withdrawn, how many, you understand. So when I was part of that team, my suggestion was each and every court should employ at least therapists, not government therapists, private therapists, because remember, with private, you give each and every person attention. So if that can be offered, but then be part of a legislative format, so that we know that if there's a GBV case, if there's somebody, especially if it keeps on coming in, I would get a lot of people that will come in and out many a times, drop the case, come back, drop the case, come back. And you can see that this is more into just this GBV. There's a lot into this woman who keeps on dropping this casing and coming back and dropping it off. So when we get therapists that are psychologists that are set a part of the law or the legislator or whatever, when they put the laws to say, when you open a GBV case, you must know that you will meet a psychologist, somebody who will have to go within you, so that we know how to further continue with this case, because they continue with this case based on what a social worker is saying from court. Oh, no case can be withdrawn, she's fine. And remember, because there's so many cases, the people that are working with these people, they tend to take each and every case like another case. Oh, it's the same as last week. Oh, it's the same as yesterday. Oh, it's the same as next week. They don't treat it as per person. And that's how I discovered when I was in private. To say when I was with the government, I was mostly just seeing people for the sake of paperwork. But when I was private, I would understand each and every person that comes into my office and understand how, when, and who, and why are you not doing this ever again, or get out of that relationship. So there's a lot of psychological therapy that needs to be done with the GBV cases. And just one more before I close off the topic, even with rape cases, I have a scenario of a friend who was so afraid of her parents that when the news came out that she cheated on her husband, she said, oh my goodness, I wanted to say this. I feel like I was raped because I was under the influence. I'm like, after 6 months now, because the story is out, you are crying rape. I'm not saying that you were not raped. I'm just saying that as a person who went through a difficult situation, you could have spoken to 3 or 4, 5 people. Why are you waiting for the story to come out and it looks embarrassing, and then now you are screaming rape? Now, when it gets to the court, such cases, they overlook at them, they throw them on the side, and they don't even listen.
Hello, Brucey, we're losing you a little bit at the end. Can you hear us?
Can you hear me now?
Okay, I think we can hear
Yes.
you now, yeah? We lost the last
Okay.
part you said.
Oh yeah, so I was saying that, so we need people that will understand people's behaviors, because that's what we study. We study people's behaviors, people's personalities, and why people are doing the things. Then when we understand that, it's easy to work with somebody so that they don't end up opening a case because of how they feel, but not what they're going through. So I would advise that if I were part of the panel or part of people that would do policies, I would say put a psychologist. We've got so many of them. They wouldn't say they are lacking. There's a lot of them sitting without jobs. So they would do so much justice in terms of the GBV, sexual harassment, rape cases, all of these things to help, because somebody's dignity needs to be, hold back or being protected at some point. Yeah.
Thank you so much, Brucey. And also, I'd like to just add, you can let me know who those psychologists are who don't have jobs. We might have a place for them in our technologies.
Okay, I will definitely.
Please email me afterwards. Speaking about accessibility, I think that was the biggest thing coming through. It's the accessibility and the education. And doctors are not psychologists or social workers or therapists, but we, as within our company, I didn't even mention the app that we've developed. It's called My Pocket Health, and I've actually seen so many more patients on there who see me virtually, and they are just more comfortable to speak about the things that are bothering them that they would speak to a therapist about. And just because they actually have more time to just share their feelings. So that's one way that we've now added accessibility, and patients to just feel more comfortable to share, that they don't have to speak about their diabetes, they can also speak about their mental health issues. Yes, so just to close off, we have got 4 minutes left. I think the biggest thing that came through today was just being empowered through education. As I saw, that is CTU's vision there as well. And yeah, I just want to add one last thought. I don't know if any other of you, the speakers, want to add any last thoughts. Are there any?
Can I ask a question?
Yes, we've got 4 minutes.
I think, sorry about that. I think it's just based on what you've mentioned in terms of the app and the accessibility. So you can answer it, or anybody, any of the speakers are also welcome to answer it. And I think it's, we do speak about women and all that, and I know with the work that I do, it's just the funds are a bit lacking, and the resources in terms of capital and human capital. But it's really how do any of the speakers, maybe in the work that they do, how do they get to the townships? How do they get to the rural women? Because I think the lack of information and education is felt more there than it is in the urban areas. You know, maybe if they do have partners that they can work with, and maybe something that I could learn from is how do you access the women that really need our services, but maybe can't get into town and into the urban areas? Thank you.
So that's just definitely a big thing for us within the company. I know that touching on rural areas, like the data and the signal and Wi-Fi things might be an issue, but with our app, that is one of our pillars. It is making healthcare more accessible and affordable. Because, I mean, most people, you know, have a cell phone. Whether they can't afford bread, most of the times they do. We see it with our patients. Our clinics are in Mitchells Plain, Athlone, Woodstock, and a lot of our patients, they do have cell phones. And the biggest thing that we wanted was creating that accessibility and making it more affordable. So our yes, because I know they can go to the government facilities and then they wait so long because sometimes the issues are not, you know, in the red cases, you know, where they are, you know, between life and death situations. But sometimes these cases need to be seen in a different way, and that is why the virtual care has been such a big win for us, because we're accessing those inaccessible people. So that's just from our side what we're doing. So I think there needs to be more of those types of things where we actually go into those communities. And another thing before we end is that we're working on is we're partnering with platforms that can actually get into, you know, the spaza shops and the informal settlements. That's the types of things we're working on with My Pocket Health. So we're trying to get into those inaccessible places, and I think there just needs to be a lot more of that. I hope that answers your question. And I'm so happy to have met all of you panelists here today. Thank you for your time. Thank you for taking the time out. I think this webinar will be recorded, so you can get the recording afterwards. So thank you, everybody. Have a lovely afternoon further. I think we're on our last few seconds.
Thank you.
Thank you so much. Thank you.
Bye.
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 Bye. Thank you, guys.